Ovarian teratomas are germ cell tumors made of tissue from one or more embryologic germ layers. The most common one you'll see is the mature cystic teratoma, also called a dermoid cyst. It's usually benign, but it has a high-yield complication you must recognize fast: torsion. In reproductive age patients, mature cystic teratoma is among the most common ovarian tumors. Many are incidental findings on ultrasound. For exams, remember, usually unilateral, slow-growing, and clinically important, mainly because of its complications rather than aggressive behavior. Symptoms range from none at all to pelvic pressure, bloating, or urinary frequency. The presentation that should immediately change your urgency is sudden, severe unilateral pelvic pain, often with nausea or vomiting. Torsion until proven otherwise. On imaging, the key clue is fat within an ovarian mass. Ultrasound may show mixed echogenicity, and calcifications can appear too. You don't need every named sign. Just anchor on a fat-containing ovarian mass, pointing strongly toward a dermoid. Grossly, it's often a cyst filled with oily, sebaceous material and hair. A classic feature is the Rokitansky protuberance, a mural nodule where you may find teeth, bone, or cartilage. From a pathology workflow standpoint, sample the solid areas well. Microscopically, mature cystic teratoma is defined by mature, well-differentiated tissues. The classic is skin, keratinizing squamous epithelium with adnexal structures, but you can also see cartilage, fat, or respiratory epithelium. The key diagnostic point is what you do not see: immature neuroepithelium. Torsion is the most common acute complication. Pathologically, torsion leads to hemorrhage and infarction, and reactive changes can look alarming. This is where Histopath correlation matters. Don't overcall reactive atypia as malignancy in an infarcted ovary. Rupture is less common but important. Spillage of sebaceous contents can trigger chemical peritonitis and intense inflammation. Clinically, it can mimic infection or even malignancy because the inflammatory response can be dramatic. Malignant transformation is rare, but it's a classic exam topic. The most common malignancy arising in a dermoid is squamous cell carcinoma. Risk increases with older age and larger tumors, so pathologically, the solid areas deserve your best sampling. The key malignant differential is immature teratoma. Instead of mature tissue only, you find embryonal elements, especially primitive neuroepithelium. These tumors tend to be more solid and behave malignantly, so that single microscopic phrase changes staging and management. Teratomas also have monodermal variants. The most famous is struma ovarii, composed predominantly of thyroid tissue, and it can even cause hyperthyroidism. For exams, it's a pattern recognition win. Teratoma doesn't always look like hair and teeth. From a histopathology perspective, a mature cystic teratoma is confirmed by identifying mature tissues, classically squamous epithelium with skin adnexal structures, within an ovarian cyst. Final recap: a fat-containing ovarian mass suggests dermoid, but sudden unilateral pelvic pain with nausea or vomiting is torsion until proven otherwise. Subscribe to Histopath Academy because we teach medicine with pathology at the core.